Permanent Subcommittee on Investigations will come to order. Before we begin this hearing, guests and viewers should be advised that this hearing will discuss the medical abuse of women in the custody of the U.S. government, and that this subject matter is deeply distressing and highly sensitive. 18 months ago, I launched a PSI investigation focused on the medical treatment of women detained by the Department of Homeland Security. This investigation has been bipartisan from start to finish, and I'd like to thank Ranking Member Johnson and his staff for their contributions. Our findings are deeply disturbing. It is the bipartisan finding of the subcommittee that female detainees in Georgia were subjected by a DHS contracted doctor to excessive, invasive, and often unnecessary gynecological surgeries and procedures with repeated failures to obtain informed medical consent. This is an extraordinarily disturbing finding, and in my view represents a catastrophic failure by the federal government to respect basic human rights. Among the serious abuses this subcommittee has investigated during the last 2 years, subjecting female detainees to non-consensual and unnecessary gynecological surgeries is one of the most nightmarish and disgraceful. The subcommittee has been thorough, interviewing more than 70 witnesses and reviewing more than 540,000 pages of records. And I want to thank and commend the staff who have worked on this for the last year and a half. The subcommittee engaged medical experts, including Dr. Peter Sharuni, OBGYN, who has previously conducted medical reviews of other matters for the HHS Inspector General, and who independently reviewed more than 16,000 pages of medical records obtained by the subcommittee. The subcommittee also consulted Dr. Margaret Mueller, OBGYN, who has also reviewed extensive medical records related to the investigation. Both Dr. Sharuni and Dr. Mueller will testify today, and I thank you both for your service to the subcommittee and to the U.S. Senate. These medical experts reviewed the clinical conduct of Dr. Mahindra Amin, an OBGYN doctor contracted by the Department of Homeland Security, who has subjected female detainees to aggressive and unethical gynecological care, quickly scheduled surgeries when non-surgical options were available, performed unnecessary injections and treatments, and often proceeded without informed consent. In addition to this expert review of medical records, the subcommittee analyzed relevant data secured from ICE, and the results of our analysis were shocking. For example, from 2017 to 2020, Dr. Amin accounted for just 6.5% of all off-site OBGYN visits for all ICE detainees nationwide. Yet during the same period, this single doctor, according to ICE statistics, performed 82% of all dilation and curettage surgeries, 93% of all contraceptive injections, and 94% of all laparoscopic surgeries to remove lesions performed on the entire ICE detainee population nationwide. Let me reiterate those statistics. One doctor, 6.5% of OBGYN visits, 82% of DNC surgeries, 93% of contraceptive injections, 94% of laparoscopic surgeries to remove lesions performed on the entire nationwide ICE detainee population. The subcommittee sought an interview with Dr. Amin during this investigation, and when he declined, we issued a subpoena. Dr. Amin invoked his Fifth Amendment right not to testify and has not spoken with the subcommittee. We will also be joined today by an extraordinarily courageous woman, Karina Cisneros Preciado. Karina was born in Mexico and brought to the United States as an 8-year-old child. She began working at 15, and by 18 was married to a spouse who physically abused her. After she called the police to her home during an incident of domestic abuse, Karina was arrested And although all charges against her were dropped, she wound up detained at Irwin County Detention Center in Osceola, Georgia, because of her immigration status. Just 4 months earlier, Karina had given birth to her 4-month-old daughter, who was still breastfeeding at the time. Now forcibly separated from her infant daughter, Karina had not yet received her postpartum exam and sought care while in detention. Karina was sent to Dr. Amin. As we will hear, her encounter with Dr. Amin left her deeply disturbed. And it may only be because some allegations of medical abuse became public at this time that Karina was spared further abuse. On behalf of the U.S. Senate, Karina, I thank you for your decision to join us here today and your service to the country. Today we will also question Dr. Stuart Smith, who leads the ICE Health Service Corps and is responsible for all medical care provided to all ICE detainees nationwide. Dr. Joseph Kufari, the DHS Inspector General, and Dr. Pamela Hearn, Medical Director for LaSalle Corrections. Among the essential questions we will ask today: why are doctors who treat detainees not properly vetted by the Department of Homeland Security, when such a vet would have revealed in this case that the doctor in question had been previously sued by the Department of Justice and the state of Georgia for performing excessive and unnecessary procedures, had been dropped by a major insurer for excessive malpractice claims, and was not board certified? What due diligence did the Department of Homeland Security perform in signing off on each of these procedures? Because indeed, they did sign off on each of these procedures. Why was the inexplicably high number of surgeries performed by a single physician not a red flag that attracted greater scrutiny? What responsibility is borne by the private detention center operator for mistreatment of detainees housed in their facilities when that mistreatment occurs at an off-site medical facility? All of these and more will be the subject of vigorous questioning today. Senator Johnson will be joining us later in the hearing, and at this time I'd ask unanimous consent to enter his opening statement into the record. We will now call our first panel of witnesses for this afternoon's hearing. Ms. Karina Cisneros Preciado was formerly detained at the Irwin County Detention Center in Osceola, Georgia. Dr. Peter Sharuni is a medical expert the subcommittee engaged to conduct a review of medical records of patients treated by Dr. Amin who were detained at Irwin County Detention Center in Osceola, Georgia. He will be testifying remotely. Dr. Margaret Mueller is a medical expert and physician who was part of an independent medical review team that conducted a review of medical records for detainees treated by Dr. Amin. I appreciate all of you for being with us today and look forward to your testimony. The rules and custom of the subcommittee require all witnesses to be sworn in. So at this time, I would ask you to please stand and raise your right hand. Do you swear that the testimony you are about to give before this subcommittee will be the truth, the whole truth, and nothing but the truth, so help you God? Let the record reflect the witnesses answered in the affirmative. You may take your seats. We'll be using a timing system today. We ask that you try to limit your opening statements to around 5 minutes, but if you need a bit more time, it's not a problem, just let me know. Ms. Cisneros Preciado, thank you again for joining us, and if you're ready, we'll hear from you first.
Is it on? Okay, sorry. Good afternoon, and thank you for the opportunity to share my story with you today. My name is Karina Cisneros Preciado. I was brought to the United States when I was 8 years old. I am now a 23-year-old mother of 2. I have a 1-year-old and a 2-year-old. When my daughter was 4 months old, I called the police to stop ongoing abuse from her father. This led to me being arrested. And even though the charges were dropped, I still ended up at ICDC for almost 7 months, away from my daughter, away from my family. At ICDC, I became 72176 instead of Karina. At ICDC, I went through hell. This place was extremely filthy. The showers were moldy. The water cooler where we drank water from, there was mold in the spout. We were giving dirty and used underwear to wear. At ICDC, I sought help, medical help, because I had not had my postpartum checkup for my daughter. After several requests, I finally got an appointment to see a doctor. The nurse told me I was going to get a pap smear. When the day came, they handcuffed me, they put a chain around my waist, all the way down to my ankles. When we arrived at the clinic, we're taking in one by one by an escort, and the rest stay in the car with another officer. In the clinic, they took my blood pressure, my temperature, my weight, with my handcuffs still on. Once in the room, they took my handcuffs off so I could get undressed. When Dr. Amin comes in, he doesn't acknowledge me. He doesn't say a word. He just sits in front of me and starts prepping for the procedure, which he does not explain. Then he just says, "Open your legs," and continues with, "It's going to be cold," and inserts a white tube inside of me. He wiggles it around roughly. It was extremely uncomfortable. As I'm about to look at the monitor that's next to me, he immediately pulls it out and he tells me that I have a cyst on my left ovary and that I'm going to get a Depo shot for it. And if the cyst does not dissolve in 4 weeks, I'm going to have to come back for surgery. Then he asks the nurse, "How many more?" And he just walks off. I get dressed and they put the handcuffs back on. And another nurse comes in and she gives me the shot on my arm and makes me sign a paper, which I didn't have a chance to read it or hold it. I was wearing handcuffs. I just signed it. And back in the van, the other women asked me if I had gotten the shot to not have babies as well. I didn't know what it was. It wasn't explained to me. That's when I learned it was birth control. And if I would have known, I would have said something, as the women in my family had very bad experiences from birth control. When we get back to ICDC, I learned the story of many other women that Dr. Amin told the same thing to. They all had cysts on their ovaries, they all got shot, and some of them even got surgeries. I thank God that the news came out because he didn't get to do anything else to me. I'm sorry. The reason I'm telling this story is because this shouldn't happen to anyone anymore. We're not animals, we're human. We're not just a number. Thank you for your time.
Thank you, Ms. Cisneros Preciado. Dr. Mueller, we'll hear from you now, please.
Good afternoon, Chairman Ossoff, senators, and staff, as well as guests.
Could you ensure that your microphone is on, please? You'll see, I think, a green light.
It is lit up. Is this better?
Yes, thank you.
Okay. Good afternoon, Chairman Ossoff, senators, and staff, as well as guests. The first thing I want to do is take this opportunity to praise Karina for her courage and bravery for coming today. Although difficult to hear and heartbreaking, it certainly gives voice to the medical records that I reviewed and my colleagues reviewed as well. My name is Margaret Mueller. I'm a physician and I hold specialty board certification in OBGYN and subspecialty board certification in female pelvic medicine and reconstructive surgery. I have a faculty appointment at Northwestern University Feinberg School of Medicine, where I serve as the program director for the Female Pelvic Medicine and Reconstructive Surgery Fellowship. As mentioned, I was part of an independent medical review team made up of 9 other board-certified OBGYNs and 2 nurse practitioners. In 2020, we reviewed the medical records of 19 women who alleged medical abuse and mistreatment while in detention at Irwin County Detention Center. Since that summary was prepared and published, I reviewed additional medical records that make it clear that this pattern of mistreatment and abuse was not limited to those 19 women. Our findings identified a disturbing pattern of overly aggressive gynecologic care, many times involving unnecessary diagnostic procedures, and in some cases, unnecessary or inappropriate surgical procedures. Often, significant steps in the appropriate evaluation and management of common gynecologic conditions were completely omitted, leading to these unindicated and unnecessary procedures. Our review more concerningly identified a serious failure by the facility-assigned gynecologist, Dr. Amin, to obtain meaningful informed consent from the women who he was treating. The unindicated and under-consented procedures included transvaginal ultrasounds, which is a procedure in which a woman is undressed from the waist down and a medical professional inserts a wand or probe into the vagina to image the reproductive female organs, the uterus, cervix, fallopian tubes, and ovaries. Pap smears, again a procedure in which a woman is undressed from the waist down and a medical professional inserts a speculum into the vagina and a brush is used to exfoliate the cervical cells to send to the pathologist. A LEAP procedure, a procedure in which typically this is performed in the office. However, under Dr. Amin's care, this was performed in the operating room under anesthesia, where again a speculum is inserted into the vagina and electrocautery is used to burn or remove or cauterize a significant portion of a woman's cervix. Dilation and curettage, which you've heard about, a surgical procedure which is performed again in an operating room under anesthesia, where a speculum is inserted into the vagina and instruments are used to sequentially dilate or open a woman's cervix, obtaining access to the endometrial cavity or inside of the uterus. Once that is done, a separate instrument is used to scrape the inside or lining of the endometrial cavity to provide a pathologic specimen. And finally, laparoscopy, a surgical procedure in the operating room under general anesthesia, where one or more small incisions is made in the abdomen, a camera is introduced, and different instruments are used to either remove or repair tissue or organs. Additionally, in several cases, women actually had incorrect procedures performed by Dr. Amin. These incorrect procedures resulted in, number 1, a woman being inadequately treated for a cervical cancer, and number 2, a reproductive aged woman undergoing unnecessary removal of a significant portion of her cervix. Just as examples, due to these incorrect procedures, both women can expect to require further and future procedures and monitoring, none of which would have been necessary had the appropriate procedures been done in the first place. All of these procedures involve risks. Those risks are those that are directly attributed to a procedure, for example, an injury to a bowel or a portion of the intestines at the time of a laparoscopic procedure, and those that are downstream consequences, preterm birth or preterm labor following a LEAP procedure, or infertility and fertility implications following a dilation and curettage. These unnecessary medical procedures were performed without an adequate consent, which means more than just placing a signed consent form in a chart, but a documentation of an appropriate discussion of less invasive options that might be appropriate for the management for a patient, thus signifying a meaningful shared decision-making discussion between a patient and her physician. This lack of adequate informed consent was apparent from the medical records, but corroborated further by the stories like you heard from Karina, where really it was identified that there was a total absence of shared decision-making in the process between the patient and the physician. An informed consent discussion should explore, number one, the patient's symptoms and degree of bother from those symptoms. Number two, the full range of treatment options available for a specific condition, ranging from least invasive, for example, observation if appropriate, to most invasive, as an example, surgery. And then finally, the risks, the benefits, and the alternatives of all of those proposed management strategies. Importantly, if a patient has no symptoms or has no bother by her symptoms, or if a particular surgery is unindicated, then the intervention exposes the patient to unwarranted risk without any medical benefit. Finally, many of these concerns are magnified by the vulnerable nature of these women. As you've heard, many of these women identify as trauma survivors. Several report a history of either rape, sexual abuse, or sexual assault. All were incarcerated and unable to choose a medical professional with whom they felt comfortable. In that setting, these women were forced to relinquish their autonomy and their decision to participate in their own medical care. Autonomy is one of the 4 pillars of medical ethics and represents a patient's right to make decisions regarding her health care, without the medical provider trying to unduly influence her decision. More simply stated, it is the right to refuse or choose medical care without the fear of retaliation. By nature of their incarceration, these women did not have a choice in what providers they saw. Some were retaliated against when they asked for a second opinion or refused surgery with Dr. Amin. This further compounds the concerning pattern of care that we identified. The manner in which these women were treated, as they were subjected to aggressive, unnecessary, unindicated, and incorrect procedures and surgeries, often without any benefit and usually without informed consent, is unacceptable by any standard. This cannot be allowed to happen again. Thank you very much for your investigation and your time today. I look forward to your questions.
Thank you, Dr. Mueller, for your testimony. Dr. Sharouni, we'll hear from you now, and Dr. Sharouni will be joining us remotely.
Chairman Ossoff, members of the Permanent Subcommittee on Investigations, all other interested parties and staff, good afternoon. My name is Peter Sharouni. As you've heard, I'm currently Professor Emeritus at the University of Vermont in the Department of Obstetrics, Gynecology, and Reproductive Sciences. I assume I did send in a CV and you have heard some about that. Particularly, I have extensive experience in quality assessment and improvement in medical care, and I've previously been involved with reviews within the United States government, as you have heard, as well as internationally, including the obstetric care review that was mentioned within the Indian Healthcare Service a few years ago. I'll try not to be repetitive, as most of what, if not everything, Dr. Mueller said was accurate in my review, but I'm coming from the quality side. I was asked to review the obstetric and gynecologic care of the immigrants within the United States Immigration and Customs Enforcement custody at the Irwin County Detention Center. The medical records included those from the detention center, from Irwin County Hospital, and the provider of record, Dr. Amin. Of note, I will mention that I wasn't involved in the selection of the patient's records for review, and I don't have knowledge of the provider's accessibility to the patients from the detention center. As time's limited, I'll move on to the summary of my findings. The main point of concern, as you've already heard in the provided care, is the use of in-hospital surgical procedures for assessment of patient complaints regarding things such as irregular menstrual bleeding, also known as menorrhagia, metrorrhagia, dysmenorrhea, or pain. In-hospital dilatation of the cervix and curettage of the uterus, the commonly called D&C, and exploratory laparoscopic procedures of the pelvis and abdomen, as you've heard, placing a lighted camera into the abdomen to look at the pelvis and evaluate what's going on, that these have largely been replaced by advanced imaging techniques and outpatient medical treatment options in order to establish diagnoses and proceed with definitive patient care. The provider does use some of these diagnostic tools, but often incorrectly and without adequate documentation to be useful. Two examples of these would be the use of Depo-Provera shots, if you've heard, progesterone hormonal shots, for the management of regular menstrual bleeding without allowing sufficient time for a therapeutic effect of this intervention. Also, vaginal ultrasound, for which the provider does not follow guidelines for either performance or documentation proposed by our professional organizations such as the American Institute of Ultrasound in Medicine. During the surgeries, the provider often performs resection or removal of benign lesions, such as ovarian cysts and fibroids of the uterus, which have not been shown to be contributory to the patient's complaints. On a few occasions, he aspirates ovarian cysts, which is not a recommended treatment. Of additional concern, the provider's pap smear management is outside of guidelines, and providers' colposcopic skills and documentation, as well as cervical conization skills, as you heard from Dr. Mueller, appear limited for several patients. These are essential steps within the abnormal pap smear care flow. Colposcopy is essentially using a magnifying glass to better visualize abnormalities which have been previously reported on a pap smear, and cervical conization, again, as you've heard, is surgical removal of a cone-shaped piece of tissue from the cervix to get pathologic evaluation of the abnormalities suspected from the pap smear and colposcopic impression. Of importance, there are patients within this review where no follow-up is documented, where the treatment resulted in no answer. That is, the way the surgery on the cervix was performed resulted in no useful tissue for a pathologic evaluation or diagnosis that could guide further care. And that's the whole point of the procedure within the diagnostic and care algorithm of pap smears. Other concerns, I can expand on it if you like during questioning regarding treatment of vaginal infections, intrauterine device management, treatment of condyloma cuminata, also known as venereal warts, diagnosis of endometriosis and adenomyosis, and documentation of both options for care and consent are noted. Thank you for the opportunity to help in the quality assessment and improvement of care for this population.
Thank you, Dr. Sharouni, for your testimony, and thanks again to both Dr. Sharouni and Dr. Mueller for the many hours of work that you invested in helping the subcommittee understand the records that we secured. We will now turn to a first round of questions for our first panel of witnesses, and I'll be asking the first questions. Ms. Cisneros-Preciado, we'll begin with you. I want to begin by again thanking you for your testimony and your presence here. It's deeply appreciated. It took courage, and I'm grateful that you're here and sharing what you've been through with the American people and the U.S. Congress. I want to review just a little bit about your story and how you came to be detained at Irwin County Detention Center in Osceola, Georgia. It's my understanding that you were brought to the United States when you were just a child, is that right?
Yes.
How old were you?
I was 8 years old.
8 years old.
Yes.
Have you ever known a home other than the United States?
No.
You currently live in Florida, is that correct?
Yes, sir.
And you're the mother of 2 children?
Yes.
How old are they?
I have a boy. He's 1. And my daughter, she's 2.
Before you were detained at ICDC, had you ever had any kind of trouble with the law?
No, never.
You were in an abusive spousal relationship, correct?
Yes,
And you called the police during an incident?
I did.
But rather than arresting your partner, you were arrested, is that right?
Yes.
and the charges were dropped,
Yes.
but you wound up at Irwin County Detention Center.
Yes.
Tell us a little bit more about your experience there, please.
Well, Irwin is the worst place I've ever been in my life. Like I said, I went from being Karina, a mother, to just being 72176. They didn't care about what we felt. They didn't care about our names. They didn't care about none of that.
And you had just given birth to your daughter, is that right?
Yes.
Was that about 3 months beforehand?
Yes, my daughter was 4 months.
I think you mentioned in a statement you'd submitted that you were still breastfeeding your infant daughter,
Yes, I was trying to breastfeed her.
and you were taken from her.
Yes.
And how long were you detained at Irwin County Detention Center?
Almost 7 months.
7 months away from your newborn daughter.
Yes.
What was it like when you were reunited with your daughter after you were released?
It was a mixture of feelings because when I left her, she was just a baby. When I came to see her, she was already walking. She didn't know who I was. She knew my mother as her mother. She was scared of me. She wouldn't come to me. It was hard, but it was the best moment because I got to see her again after so long. After crying for her every night, after wishing a lot of times that I just didn't wake up anymore if I was not going to wake up next to her. I finally got to see her. And it is extremely hard for me to be here because I left her. I left her again. And although it's for the better, for the both of us, she's away from me right now, and it's really hard for me.
Take your time.
Sorry.
No problem. Now, when you arrived at Irwin County Detention Center, you had not yet had your postpartum exam. Is that correct?
Correct.
So you requested medical attention.
Yes.
And after some difficulty, you wound up, as you said, in Dr. Amin's office.
Yes.
And how did that experience make you feel?
It made me feel like I had no control over my body. It was... Before this experience, I had suffered from sexual assault before as a child. So this kind of... The experience with Dr. Amin made me feel the same thing I felt. It made me feel like I had no control over my body. I had no say, no vote, no nothing. When he didn't explain the procedure, and he was doing a vaginal ultrasound because I know it was a vaginal ultrasound because I had that done before. I didn't think I could ask any questions. As the nurse had told me I was getting a pap smear. I didn't ask any questions. I thought I couldn't. He made me feel miserable.
During that appointment, Ms. Cisneros Preciado, did Dr. Amin address any of your concerns, allow you to ask any questions, explain what he was doing?
No.
And he prescribed an injection in addition to conducting a transvaginal ultrasound, is that correct?
Yes.
Do you know what the injection was?
I didn't know when he didn't explain what it was. I learned after in the car when one of the other women told me what it was.
And as you mentioned in your opening statement, you heard from other women that other women had experienced a similar pattern of treatment
Yes.
from Dr. Amin. Did anyone ask for your consent to receive that shot? Did you sign any documents?
They didn't ask anything, and I signed a paper, but I didn't know what it was. They just told me sign here, and like I said, I didn't have a voice, so I just signed.
Thank you, Ms. Cisneros Preciado. Dr. Mueller, you reviewed extensive medical records,
Correct.
as has the subcommittee. And one of the things I think is important to make clear is that the experience that Ms. Cisneros Preciado just related to us is by no means unique. In fact, it's consistent with a pattern that we see in the care that was provided by this physician to women who were incarcerated, to women who were powerless. Can you talk a little bit about how what Ms. Cisneros Preciado just described conforms with the broader pattern that you saw in the medical records, and then reflect for a moment as a practitioner on the particular sensitivity required when treating people who are incarcerated? And at that point, I'll yield to my colleague, Senator Hassan, for her questions.
Absolutely. After Karina spoke, I mentioned that really she does give voice to the medical records. As you mentioned, this was repeated over and over and over again. Almost all of the women who came to see him for either a gynecologic concern or something unrelated received a depot shot for unclear indications, received pap smears when they didn't need a pap smear, were managed incorrectly or inappropriately following that. Again, I'm a medical expert. My role is to review the medical records, but it was such a concerning pattern that it gave you pause, and I'm starting to understand perhaps why this was happening. Karina also mentioned and gave further insight, now that you can all experience this, that this is a very vulnerable population. This is not like your mother or your sister who gets to go on Yelp and look to see who has the best reviews, or see a provider for the first time and see if she feels comfortable in the hands of that provider who's going to be taking care and guiding her through choices and medical management, et cetera. This is not a provider that many of these women would have ever wanted to go back to. Clearly, he did not take this seriously. He was not operating from a standpoint of providing trauma-informed care, realizing that this is a vulnerable population, taking a history that would indicate that a woman has been a survivor or victim of a sexual assault. This is basic standard medical school equivalent to just performing a basic history and physical, which without that, you actually, again, to the point of informed consent, cannot have a meaningful informed consent because you have no understanding of the risks that you might be exposing a patient to in their medical history.
Thank you, Dr. Mueller. Senator Hassan.
Well, thank you, Chair Ossoff, and I want to thank you and Ranking Member Johnson for holding this hearing and for the investigation. To Ms. Cisneros Preciado, thank you for coming forward. It is extraordinarily difficult to do what you're doing and to share such personal information. I hope you will take some solace in knowing that it's by sharing information in the way you are sharing it that we are able to move forward and change. Your courage is really remarkable, and you're making a difference for others. So I hope that gives you a little bit more solace today. This is difficult, I know. It was very disturbing to hear and to read your testimony on a number of levels, obviously, but I was very concerned that you didn't have a chance to ask any questions when you were seen by Dr. Amin, and that you didn't feel that you could say no to what he planned to do. So I want to follow up on Senator Ossoff's questions. Just to be clear, did Dr. Amin ever ask questions about your medical history or whether you had any previous cysts?
No.
Did he explain or provide any other treatment options for the cyst he reported? Or did he provide any chance for you to discuss your treatment options?
No, he didn't.
Okay. Thank you. I have a question for both Dr. Mueller and Dr. Sharouni. Dr. Mueller's testimony says, and this is a quote, "If a patient has no symptoms, is not bothered by her symptoms, or if a particular surgery or intervention is not indicated, then that intervention exposes the patient to unwarranted risk without any benefit. The subcommittee found that the ICDC doctor performed an unexpectedly large number of invasive procedures on women from its facility. 90% of 4 types of invasive procedures performed on all ICE detainees were performed by Dr. Amin, despite the fact that ICDC housed just 4% of the national female detainee population. So starting with you, Dr. Mueller, what is your best assessment for why a doctor would perform such an extreme number of invasive procedures on these women?
Thank you, Senator, for that question. Of course, as a medical expert, I can review the medical records and tell you if this was beneath the standard of care, what is typically done, et cetera. It is difficult for me to be able to comment on the motivation behind that type of medical care, but I do think that you shed light onto potential motivation. I think that potential motivations could include billing, et cetera. Again, my role as a medical expert is to comment on the medical records, but just as a person, I would surmise that.
Yes, and I understand your role, but it's also generally true in my experience that reimbursements are more clear and sometimes better for actual procedures as opposed to consultations. Is that an assessment or a statement you generally agree with?
Typically, depending on the contract set up, you
Right.
know, certainly if this is something that if there is some reimbursement incentive for the amount of procedures, then yes, that would be a motivation.
Thank you. Dr. Sharouni, the same question to you. Do you have an assessment of why a doctor would perform such an extreme number of invasive procedures on these women?
Senator, thank you for the question as well. Coming from the quality aspect, it's important that I outline that when we look at quality improvement and assessment, we don't include punishment, if you will, associated with that. And that's very important so that you get the good quality information you need to do adequate quality assessment and improvement. Anywhere from just simply a lack of knowledge or an ease of a way to move forward are reasons. Certainly using what would have been a somewhat standard medicine 30 years ago, perhaps, with what we have today and the dramatic improvement in both medical care, in other words, not surgical care, as well as the advancement in medical imaging. Medical imaging has really helped to drive a better assessment of surgical necessity, which really I can't say was used in this case because the physician's skill around vaginal ultrasound, which is predominantly what he used, sometimes at the hospital, but most times in his office, showed just a lack of documentation that was hard to say it was successful, and it helped with the care of the patient, other than finding benign lesions for which he used those as indications for surgery, which I would also say is outside the current quality demands of gynecologic care.
Thank you. I have one additional question, and it is to Dr. Mueller. Your testimony stated, Doctor, that you and the medical review team found a disturbing pattern of overly aggressive medical care, sometimes involving unnecessary procedures. Your testimony also noted that some women presented with symptoms that were not appropriately evaluated, diagnosed, or managed despite the patient undergoing invasive surgical procedures. Your testimony further explains the general requirements for informed consent. Could you elaborate on what information should be shared with the patient? What requirement or expectation is there regarding possible language barriers as well?
Yeah, thank you, Senator. You bring up a great point. Yes, in order to have a meaningful informed consent discussion to adequately reflect shared decision-making between a patient and her physician, you would need to take away any barriers, language being one of them. So in any of those informed consent discussions, there should have been an interpreter present or utilized. It is very important to understand that consent is not a signed piece of paper. Consent is a discussion between the physician and the patient. Again, you would need to know the patient's background, medical history, allergies, et cetera, prior to having an informed consent, the symptoms or the bother, and then explain to the patient and document the range of treatment options and explicitly what those risks are in that setting.
And based on that testimony, it seems to me, and based on the report, that the women detained at the ICDC have received a far lower level of care that they should have received. Based on your testimony, the work of the medical review team, and this subcommittee's investigation, it appears as though many, if not most, patients seen by Dr. Amin had little to no discussion of their conditions or alternative treatment options. Weren't these women entitled to a higher level of care than they received, including at least a reasonable discussion of their conditions and possible treatment options?
Absolutely. I find this to be a grave miscarriage of justice that these women were exposed to this type of treatment.
I appreciate that. I regret the circumstances that bring us here today, but I am very, very grateful for your testimony and all of the witnesses. Thank you, and thank you, Mr. Chair.
Thank you, Senator Hassan. Dr. Sharouni, would like to turn to you to discuss the potential long-term consequences of surgery and other gynecological procedures that are not medically indicated on these women. And I want to remind everybody again who's tuned in here, we're talking about dozens of cases that the experts here have reviewed in which incarcerated women were subjected to unnecessary, often non-consensual, and extremely invasive gynecological procedures and surgeries. This is one of the most outrageous things that this subcommittee has investigated in the last 2 years. And I think, Dr. Sharouni, that it would be helpful if you could discuss for a moment what the long-term risks, the long-term impacts on health, physical and mental health, can be from that kind of mistreatment.
Sure, thank you again. Let's take a small step back and just say, again, since a large number of these procedures have been changed to the point where we can do outpatient evaluation to find the appropriate diagnostic issues with a given patient. What was used here was the D&C, as we heard, the dilatation of the cervix and curettage of the uterus, and endoscopic, laparoscopic evaluation in the abdomen as an invasive procedure, and in the vast majority of times identified benign issues which did not require intervention or were certainly not evaluated close enough to find out if that was the cause of the patient's complaint. When that happens, there's a number of things that occur, and Dr. Mueller has already touched on some of them. Consequences related to any surgery would include short-term infection, bleeding, etc., as well as longer-term scarring formation, scarring around the female reproductive organs can result in things such as infertility, adhesions, which are internal, scarring, which can cause persistent long-term pain. So these are all consequences that are not insignificant, and which is why medicine has tried to minimize the necessity for these procedures over the course of decades to get to the point where we can identify the individuals who require the surgery and where the risk-benefit ratio is optimized for them. And then their potential benefits warrant the potential risks associated with the procedure. Again, the vast majority of these patients, risk-benefit, number one, it's hard to even evaluate, much less come to a conclusion that the patient is going to overall benefit from one of these procedures.
Thank you, Dr. Sharouni, and thank you again for your service. Ms. Cisneros Preciado, would like to offer you the opportunity if you have anything you'd like to add, anything you'd like for the Senate and the American people to hear. The floor is yours.
Yes, I would like to add that because of this incident with what happened with Dr. Amin, to this day, I am extremely scared to go to any doctor for myself and for my kids. It was extremely traumatic, and I don't know if I could ever get over it. I'm scared to take my kids to the doctor. I'm scared to take them out. It's just, it was just horrible. And the reason I'm sharing my story is because I don't want this to happen to any other women or any other person in general. They shouldn't have to be separated from their families. They shouldn't have to, like, be scared to go to the doctor when we're supposed to be able to trust them. Thank you.
Thank you, Ms. Cisneros Preciado. That concludes the first witness panel at today's hearing. We will now take a brief recess and welcome the second panel to the witness table. Thank you all, Dr. Mueller, Ms. Cisneros Preciado, and Dr. Sharuni, for your attendance today.
Welcome.
We will now call our second panel of witnesses for this afternoon's hearing. Dr. Stuart Smith serves as the Assistant Director of the U.S. Immigration and Customs Enforcement Health Service Corps. Dr. Pamela Hearn serves as the Medical Director for LaSalle Corrections. The Honorable Joseph Kufari serves as the Inspector General for the Department of Homeland Security, Office of Inspector General. It is the custom of this subcommittee to swear in all witnesses, so at this time I would ask you please stand and raise your right hands. Do you swear that the testimony you are about to give before this subcommittee is the truth, the whole truth, and nothing but the truth, so help you God? You may take your seats. Let the record note all witnesses answered in the affirmative. We will be using a timing system today. Your written testimonies will be printed in the record in their entirities, and we ask that you limit your oral testimonies to approximately 5 minutes for your openers. Dr. Smith, we'll hear from you first, and you may begin. Would you mind moving that microphone a bit closer? There you go.
Chairman Ossoff, Ranking Member Johnson, and distinguished members of the subcommittee, thank you for the opportunity to appear before you today. IHSC is committed to providing quality health care services in accordance with nationally recognized detention standards. The IHSC workforce consists of approximately 1,700 healthcare provider positions comprised of federal civil servants, U.S. Public Health Service Commission Corps officers, and contractors. These positions represent a wide array of healthcare professionals throughout the United States, including physicians, advanced practice providers, registered nurses, psychiatrists, psychologists, social workers, pharmacists, dentists, and healthcare administrators. IHSC provides direct medical care or oversight of off-site medical care to diverse and fluid population. Each facility housing ICE detainees is staffed by medical care professionals 24 hours a day, 7 days a week for direct patient access. In fiscal year 2022, IHSC provided direct care to over 118,000 detained non-citizens housed at 19 IHSC staff facilities throughout the nation. In addition, IHSC oversaw compliance with detention standards for health care for over 120,000 detained non-citizens housed in 163 non-IHSC staff facilities. ICE's detained population presents unique health care challenges, and IHSC staff work diligently to improve health care and resiliency through prevention and evidence-based disease treatment. In many incidences, the care detainees receive while in ICE custody is the first professional medical care they have ever received. Consequently, it is common for initial health care screenings to identify chronic and serious health conditions which were previously undiagnosed. To fulfill our mission of delivering high-quality health care to all those in our custody, detainees receive a comprehensive medical, dental, and mental health intake screening within 12 hours upon arrival at the facility. Furthermore, they receive a comprehensive health assessment, including physical examination and mental health screening by a qualified licensed healthcare professional within 14 days. Detained non-citizens identified as high risk during the intake process are triaged for a higher level of care immediately. ICE embraces national detention standards that are recognized for detention and healthcare delivery, and ICE's integrated healthcare delivery program undergoes extraordinary scrutiny. ICE conducts regular reviews, internal audits, and on-site assessments, and when needed, implements corrective action plans. ICE detention facilities are also subject to multiple levels of independent oversight inspections by the DHS Office of the Inspector General, the ICE Office of Detention Oversight, the DHS Office for Civil Rights and Civil Liberties, and the DHS Office of the Immigration Detention Ombudsman. In December 2020, ICE learned of allegations of forced medical procedures performed by an off-site provider serving the Irwin County Detention Center through a whistleblower complaint. ICE and IHSC take these allegations and all allegations of medical mistreatment seriously. In October 2022, following the whistleblower complaint, ICE took immediate steps to discontinue sending patients in our custody to this off-site provider and to pursue alternate providers to serve the women in custody at ICDC. On November 25, 2020, ICE ceased intake of female detained non-citizens at ICDC, and on September 17, 2021, ICE ceased operations at ICDC altogether. While off-site community-based providers are not contracted to provide services with ICE or the detention facility, they are licensed medical professionals vetted by state and county licensing boards. IHSC is improving its oversight of off-site providers by establishing national care guidelines and instituting a utilization review process, an initiative started well before the allegations came to light. ICE is firmly committed to ensuring all those in its custody receive appropriate medical care and are treated with respect and dignity. ICE is also committed to fully cooperating and complying with all requests for information about these allegations from oversight bodies, including Congress. ICE and IHSC continue to fully participate in all investigations of the allegations of medical mistreatment at ICDC. Thank you again for the opportunity to speak with you today, and I look forward to your questions.
Thank you, Dr. Smith. Dr. Hearn, you may now offer your opening statement.
Chairman Ossoff, Ranking Member Johnson, and members of the subcommittee. Thank you for arranging this hearing and for the opportunity to provide testimony concerning allegations of detainee mistreatment. My name is Dr. Pamela Hearn. I serve as the Medical Director for LaSalle Corrections and have overseen medical care at the Irwin County Detention Center in Georgia since January 2020. I am responsible for the medical operations and deployment of health resources to support a number of medical facilities, including the Irwin County Detention Center's medical department. Also, I'm actively involved in performance improvement initiatives for the patients we serve. I communicate with ICE to establish clinical policy, procedures, and protocols, and analyze audit results to ensure patient care meets the expected standards. Today, I seek to clarify who LaSalle is and its limited role in the provision of outside medical services. LaSalle was founded in 1997 to address overcrowding and underfunding in state-run detention facilities. LaSalle currently manages 15 facilities in 4 states. LaSalle partners with local municipalities to provide facility management and operational services, while also providing employment opportunities and economic stability to these areas. LaSalle is led by a corporate management team. Each member has extensive professional experience in detention administration, criminal justice, and public service. Guided by this leadership, LaSalle demonstrates a deep understanding and ongoing commitment to the health and well-being of those entrusted to our care. LaSalle is committed to operating its facilities and programs with the highest levels of decency and humanity, while providing safe, secure, and humane surroundings for our staff and those in our custody. LaSalle does this in all the communities we serve, including Irwin County, Georgia. It is LaSalle's policy to ensure that all detainees have access to appropriate medical care by on-site qualified personnel who are licensed, registered, or certified with applicable state and federal requirements. LaSalle provided on-site health care service to patients in accordance with the stringent standards set forth by ICE, known as the 2011 PBNDS. Frequent independent audits verified Irwin County Detention Center met or exceeded these standards. In addition, IHSC provided consistent guidance in the form of interim reference sheets and the pandemic response requirements. Again, independent reviews substantiate the fact that LaSalle and Irwin County met or exceeded standards. At no point was LaSalle involved in the vetting or monitoring of outside providers. or the provision of translation services on behalf of patients. Nor could we have done so under the regulations governing our involvement at Irwin County Detention Center. Rather, the IHSC Credentialing Department was responsible for vetting and approving all outside medical providers, and ICE was to monitor and pay for the same. LaSalle's limited role respecting outside medical care was to ensure that outside medical providers were available and to provide transportation of the patient to and from those providers. At all times, LaSalle partners with the federal government and the agencies to provide excellent medical care and exceed the relevant ICE standards.
Thank you, Dr. Hearn. Inspector General Kufari, you may now offer your opening statement.
Chairman Ossoff, Ranking Member Johnson, and members of the subcommittee, thank you for the opportunity to discuss the oversight work of DHS-IG. Our mission is to provide independent and objective oversight of DHS. This is a responsibility that I and the dedicated career professionals of my team take seriously. It is an honor to appear before you today to discuss our oversight of medical care in ICE detention facilities. I'm profoundly grateful for the continued bipartisan support we have received from Congress. This support has included year-over-year increases in our appropriations during my tenure. As I promised HSGAC in my confirmation hearing, I have used the expanded investment in our work to augment our detention oversight with contract medical professionals. Between FY20 and 22, our office conducted 12 inspections of ICE detention facilities. In 9 of those inspections, teams of medical professionals, typically a nurse and a doctor, reviewed detainee medical files, medical staffing levels, training curriculum, medical protocols to determine whether the medical care provided to detainees complied with federal detention standards and with COVID protocols. In 7 of the 11 reports we issued from FY20 to 22, we found deficiencies in detainee medical care. In total, we made 69 recommendations, 20 of which are aimed at improving detainee medical care. In September of 20, we received a complaint about the Irwin County Detention Center. We referred the criminal allegations of forced medical procedures to our Office of Investigations and the whistleblower retaliation complaint to our Whistleblower Protection Unit. We also initiated an inspection of the Irwin County Detention Center in October of 20. I personally visited that facility in July 21. Following our established protocol, we interviewed ICE personnel, Irwin officials, and detainees. We also reviewed video surveillance of housing and common areas. Our medical experts conducted a virtual tour of the medical unit and reviewed medical records. Our inspection determined that Irwin generally met ICE detention standards. However, our medical team found the facility's chronic care, continuity of care, and medical policies and procedures to be inadequate. Our medical team found the quality of women's health care to be adequate based on records reviewed, but noted that off-site providers did not consistently share information with the facility. The facility generally complied with COVID-19 guidelines, but faced challenges implementing those protocols. We also found that detainees' communication with and access to ICE deportation officers was limited. We published our report in January 22 and made 5 recommendations to improve the facility's medical care and operations. ICE concurred with 1 recommendation and implemented corrective actions. ICE did not concur with the other 4 recommendations since in May 21, Secretary Mayorkas announced DHS's plans to discontinue the use of the facility. By September 21, ICE no longer housed detainees at Irwin. In addition to our inspections of individual detention facilities, at my direction, DHS-IG has undertaken systemic reviews of longstanding issues in detention. For example, in October 21, we issued for the first time ever a 5-year review of the use of administrative and disciplinary segregation in detention. This is the practice of holding individuals in isolation. In a separate review on medical vacancies across all detention facilities, we determined that ICE faces challenges recruiting, hiring, and retaining medical staff. Earlier this year, we launched a separate system-wide audit across all DHS detention facilities to ascertain the vigor of the approval process for invasive surgical procedures. Whether it's through individual inspections or broad systemic reviews, our recommendations continue to demonstrate to the Department, Congress, and the public our commitment to quality oversight. Mr. Chairman, this concludes my testimony. I'm happy to answer questions you or the other members of the subcommittee may have.
Thank you, Inspector General Kufari. Thank you to all of our panel 2 witnesses for your opening statements. We'll now proceed to questions. And Dr. Smith, would like to begin with you. You lead the ICE Health Service Corps, or IHSC. Its FY20 annual report states, quote, "The IHSC Assistant Director is responsible for all administrative and operational elements of the IHSC healthcare system, and consequently all activities related to the health care of individuals in ICE custody." This is you, correct? Is your microphone on?
That is correct, sir.
So you are responsible for overseeing the whole IHSC system and any activities related to the health care of individuals in ICE custody, correct? That's from your 2020 annual report.
That is correct.
In addition to your job description, ICE and IHSC are legally required, and your own manual and guidelines require, that individuals under your custody must be provided with adequate medical care, correct?
That is correct.
IHSC is responsible for ensuring the adequacy of this care for all detainees in ICE custody, not merely those at ICE-administered facilities, correct?
We do not monitor the direct patient care activities on an ongoing daily basis.
That's not my question. My question is that you are responsible, this is the quote from the annual report, you are responsible personally for all administrative and operational elements of the IHSC healthcare system, and that includes the provision of health care to detainees at privately administered facilities, correct?
Correct.
Now, it's my understanding that IHSC employees who are called field medical coordinators and regional clinical directors approve referrals to off-site providers, and the regional clinical directors approve the performance of surgical procedures by those off-site providers, such as Dr. Amin in Georgia. Is that correct?
That's correct.
And those regional clinical directors report up the chain at which you're of a top, correct?
Correct.
And they approve every surgical procedure that is referred to an off-site provider. Is that correct?
That is correct.
I want to give you an opportunity to respond to some of the specifics, some of the facts of this matter, Dr. Smith. Your opening statement was quite broad. This is bipartisan findings of the U.S. Senate's preeminent investigative subcommittee that women, ICE detainees, were subjected consistently to unnecessary, invasive, and often non-consensual gynecological surgical procedures. What's your response?
Thank you for that question, Senator. We, receiving the documented informed consent is a core principle of medical care given throughout the country. It's a core tenet of what is to occur. Documenting informed consent ensures that people understand the procedures they're going to go through and that they sign off on those and agree that they will go through those. IHSC relies on those off-site providers to obtain informed consent as they would do for any patient that receives care in the U.S. health system.
Hold on a second. If I might, you're saying you rely on those off-site providers, but you personally, as we've established, and it's from IHSC documents, are responsible for all administrative and operational elements of the IHSC healthcare system, and consequently, all activities related to the health care of individuals in ICE custody. That's from your agency. And what I'm trying to understand, Dr. Smith, is this has been a bipartisan 18-month U.S. Senate investigation, and the bipartisan conclusions of our investigation are that women whose care you're responsible for were subjected to unnecessary, invasive gynecological procedures, including in at least dozens of cases, gynecological surgeries that were not clinically indicated and that carried substantial risk to the long-term health of those women who were incarcerated at the time. Are you not shocked that this happened under your watch?
It's very troubling to hear the testimony given earlier. Obviously, we take the care of all detainees in ICE custody very seriously. As far as those, I want to be clear that we don't have our own IHSC staff at these contracted facilities. They are contracted to provide that care. Our role is to provide that oversight through different audits so that we're assured that they comply with the detention standards of care. Our field medical coordinators, when they conduct their audits, they look for those different standards of care to make sure they're complying with them. Also, and they do a quality assurance audit to make sure that the types of care that is being provided is in concert with those standards.
Let's talk about that oversight, Dr. Smith. Were you aware, was IHSC aware, for example, that Dr. Amin, whom you contracted to provide care to detainees for whom you were responsible, had previously been sued by the Department of Justice in the state of Georgia for performing unnecessary and excessive medical procedures?
When we became aware,
When did you become aware?
we became aware through the whistleblower allegation process.
All right, so my question is, were you aware at the time that you engaged his services that he'd been sued by the federal government in the state of Georgia for doing what it appears he did, again, working for you?
No, we were not.
You were not aware. Were you aware from 2017 to 2020, that's the relevant period here, that despite only seeing 6.5% of all OBGYN patients, he was performing 95% of laparoscopies and dilation and curettage surgeries? These are intrusive gynecological surgeries. Were you aware of that?
We became aware after the allegations were filed.
So you were not aware at the time?
No.
So do you vet the doctors you hire?
We don't vet them.
You don't vet them?
Let me finish, if I may, sir. The process includes these providers are not contracted directly with ICE. They are not an employee of ICE. They are referred off-site. Since these allegations, and actually before, we have been sending out different types of letters of agreement with them that they will abide by the different standards of care, that they will provide the informed consent. We now have that as part of our process. But even if these things were to show up in a national practitioner database as a red flag, it doesn't necessarily mean that they're not going to be licensed. If they're licensed in the state and they've been provided credentialing and privileging at different facilities, and we have not received any specific complaints on the physician, we will evaluate it further. And in this particular case, in Dr. Amin's case, he was the only provider in the area that was willing to see these patients. However, we were not aware of all the particulars until the whistleblower allocation.
Did you maintain any process for detecting whether or not providers working for DHS, working for IHSC, were performing an extraordinarily high number of certain procedures, which can be a classic signature, for example, of fraudulent billing?
So the process that we had in place at the time was through the claims process, where we can actually see those claims when they come in, and if there's an overbilling that's occurring, we can catch that. Oftentimes, because of the way the system was currently set up, we wouldn't see those until well after the fact. These providers have up to a year to submit their claims for processing, and at the time, that was the only process we had in place to see if there was these overbilling or debundling of services to overcharge and that sort of thing.
Let's return to the vetting. What I heard you say effectively is that you don't vet, and even if you had vetted, it wouldn't catch this kind of thing. Is that your testimony?
I'm saying that based on the lack of any derogatory information that was in a national practitioner database, specifically as to the type of care, which we weren't performing extensively at that time. We were starting to. We didn't have the ability to see that information other than through a claims process.
Well, we found that information quite swiftly. We found that the relevant provider had been sued by the federal government and the state government for excessive and unnecessary billing practices. We found that he'd been dropped by a major insurer for excessive malpractice claims. We found that he was not board certified. Those, I think, would have at least been warning signs to watch a little more carefully, and then during the relevant period, he's performing, again, 90+% of all of these gynecological surgeries nationwide, despite seeing only 6% of OBGYN patients in the country.
Right, and all of these procedures that were referred off-site were vetted through our regional clinical directors for appropriateness. And again, since then, we've expanded our ability.
Yeah, well, I'm sorry, but let me ask about that. They were vetted by all of your regional coordinators for appropriateness.
Correct.
How can that be when we've heard from medical experts who reviewed thousands and thousands of pages of records, and it's the bipartisan finding of the subcommittee that they weren't appropriate? In fact, it's not only that they weren't appropriate, they were dangerous, they were wrong, they were not clinically indicated, they were poorly executed. Women had parts of their cervixes removed. They underwent transvaginal ultrasounds and pap smears with no clinical indication for it. They underwent laparoscopic surgery when there was no need. They had their uterine lining and endometria removed in part without clinical indication. And you're saying that all of that was vetted and approved by your employees?
What I'm suggesting is when these referrals from the clinic came to our regional clinical directors to approve an off-site referral to see an OBGYN physician or a specialist, they approved that. They had no way of knowing exactly what was going to happen subsequent to that referral. Now, since then, we've got some Milliman guidelines that we are in tooling our clinical directors so that when they come in, when they see that here's the procedure that's going to be performed off-site, we've got an evidence-based protocol list that we can actually take a look at. The clinical director looks at that off-site referral as far as the referral being appropriate and says either, yes, we agree that it should be referred off-site to a specialist for further evaluation. What that evaluation may entail, we don't know until after the fact.
We'll return to this in a moment. I'm going to yield now to my colleague, Senator Padilla.
Thank you, Mr. Chair. Mr. Smith, I understand you've received a lot of questions as far today, and I have some as well, but I will give you a minute to catch your breath and address my first question to Mr. Kufari, Dr. Kufari. In your written testimony, you mentioned that following the complaints at Irwin County Detention Center, you launched a system-wide audit across all DHS detention facilities. So during this audit, did you find examples in other ICE detention facilities of women being subjected to invasive medical procedures without their consent?
Thank you for the question, Senator. Good to see you, and I look forward to visiting with you. I know our staff is coordinating a visit. That review is currently ongoing, and I'd be certainly happy to share it with you as soon as the review has been completed.
Has there been any evidence you've come across thus far, even though the review's not completed?
Nothing that would warrant our immediate notification to the committee.
Okay. You also mentioned in your testimony that facilities face challenges in the recruitment, the hiring, and the retention of medical staff. So what ideas do you offer this committee on how ICE can improve practices so that medical care is more consistent across detention centers?
I believe in our review, Senator, we found that recruitment and retention to be a significant problem. We made a number of recommendations already to the department to shore that up, to strengthen their recruitment and retention efforts, and we look forward to receiving word back from the department on exactly what their process is and how to strengthen that.
Okay. Well, eventually that comes to a question of budget and resources in which this committee and the Senate and the Congress as a whole needs to be involved. So please keep us posted.
Yes, sir.
Mr. Smith, in July of last year, ICE issued a new policy on pregnant, postpartum, and nursing individuals. Now, this policy states that such individuals cannot be detained unless their release is prohibited by law or exceptional circumstances exist. There's also a requirement that ICE Health Services Corp must maintain information on all detainees who are pregnant, postpartum, and nursing, and report this information to the ICE enforcement and removal operations. Since your office is charged with collecting this information, can you tell us whether the number of pregnant, postpartum, and nursing women in ICE detention has dropped since the policy went into effect a year ago? Okay, and we'll look forward to the underlying data behind that response. Follow-up is, what procedures are in place for ICE officers to ascertain whether an individual fits this criteria? For example, are they asking individuals to take a pregnancy test or asking if they're nursing at the time of arrest?
Yeah, so we have a female health services directive that outlines all the different types of services we do. Sorry. We do have a female health services directive that outlines all the different unique care we provide to the female population. They are screened for pregnancy as part of the intake process. And
being more specific, screened as in tested or questioned?
Urine test. Okay, so we can have a confirmatory whether they are or not. Okay. This directive also addresses elective abortions, contraception, emergency contraception, restrictive housing of female, pregnant, postpartum, breastfeeding, and all of those types of things. Okay. So unless there is a compelling reason outside of what we would have to detain this person, our recommendation is always to release.
And I'm glad you bring up the question of care beyond the test. As you know, in July of this year, following the Dobbs decision by the Supreme Court, it was reported that an internal ICE memo was going to be sent from the director to ERO reiterating that pregnant women detained in ICE custody have access to full reproductive health care, and that it may be necessary to transfer detainees to another area of responsibility to ensure such access. ICE's own 2011 standards state that women have the right to access abortion and that ICE will fund the cost if the mother was raped or if carrying the fetus would be detrimental to her health. Women can also request an abortion in other situations if they cover the cost. What is ICE doing to ensure that individuals in ICE detention are informed about their right to an abortion?
As part of the intake process, we do explain this to all the women in our custody that are found to be pregnant. We explain the termination of pregnancy. As you mentioned, ICE does pay. We provide counseling, clinical staff schedule, and coordinate any transfers for a woman that decides that she wants to take that route. If the particular state that they're in does not allow that based upon that Dobbs ruling, we recommend transport to a state that would allow that. So we at ICE in IHSC support that, and we make sure that those that would do the transfer are aware of that, and we give our recommendation.
Okay. Last question, how many individuals have been transferred to other facilities to ensure they can receive an abortion if they need or choose? And can you tell us which states they've been transferred from or to? Do you keep that level of data?
I'll take that as a get back. I don't have that with me today.
Okay, please, at your earliest opportunity. Thank you, Mr. Chair.
Thank you, Senator Padilla. Picking up where we left off, please, Dr. Smith. We've established that you personally are responsible for, and I quote from, again, your agency's documents, all activities related to the health care of individuals in ICE custody. Let me reiterate our bipartisan findings. Excessive, invasive, and often unnecessary gynecological procedures, repeated failures to secure informed consent, and ICE did not conduct thorough oversight of off-site medical providers and procedures. Do you take responsibility?
Yes, sir. Ultimately, I do. I'm the responsible party to make sure that the right processes and procedures are in place to monitor these things, and if we see things not going in the proper direction, to take the proper course of action to fix those.
Why did your agency fail?
Well, again, I believe that we provide the policies, the procedures, and we make sure that our clinicians understand what those procedures are. And we don't have direct knowledge at the time of some of these procedures happening. We're working on putting systems in place to do that through the Milliman Care Guidelines, to give our clinical directors and those that approve these procedures a template that they can use based on evidence-based standards, so they can be more informed on whether to approve an off-site procedure or not based on those standards.
I understand you say you're taking those steps now, Dr. Smith. My question is, why did your agency fail? How did you allow this to happen? How did you allow dozens, if not hundreds, of women to be subjected to unnecessary gynecological surgery? How did that happen?
Well, we weren't aware of these complaints until we weren't aware of them until we received those, the whistleblower complaint. So we just didn't have access to that information.
Why were you not aware? Why were you not aware that one doctor was performing 9/10 of gynecological procedures, but only seeing 6% of patients?
We didn't have the proper systems in place to detect that information. We started putting that process in place, though, and those systems in place well in advance of this. We just haven't got those completely implemented at this point.
What would you say to the women who went through this?
Oh, it's disheartening. It's
disheartening.
And it's very disturbing. It's very disturbing, and any responsibility that we have, we take very seriously. We want to fix this system so it doesn't happen again.
Dr. Smith, you have full responsibility. We've established that. And this is worse than disheartening.
Yes, sir.
It's hard for me to think of anything worse, really, Dr. Smith, than the federal government subjecting incarcerated women to needless gynecological surgery. It's one of the most appalling things this subcommittee has seen in the last 2 years. Dr. Hearn, I understand that you want to clarify, and you sought to do so in your opening statement, where you believe the lines of responsibility between the federal government and LaSalle, the contractor, are. I'd like to give you an opportunity to do that, please.
We provide on-site care, primary care, and any care that is deemed more advanced is referred to a specialist, an outside specialist. This specialist must be approved by IHSC in order for us to make an appointment for the...
Let me start there, Dr. Hearn. I appreciate that. The specialist must be approved by IHSC. Dr. Smith, how during the period of 2017 to 2020 did you go about approving those specialists? What was the process?
The process was that these specialists were referred, these patients were referred off-site, and we made sure we had a letter of understanding in place with them that they would receive, that they would accept the proper Medicare rates, would be the first thing, and if they were credentialed or licensed in the facility they would perform it, or in the state, then they were deemed as competent enough to provide those services.
So the only due diligence was to see if there was a valid medical license in that jurisdiction. That was the extent of your vetting.
And if they had any adverse things that were outstanding as far as direct patient care complaints through the National Practitioner Database, which we began to implement during that time.
Again, for this provider, 2005, major medical insurer drops him because of excessive malpractice claims. 2013, federal government initiates an investigation of alleged billing fraud. 1 year later, you hire him. DOJ, the state of Georgia, and the doctor settle in 2015. And then for 5 years, with apparently no vetting and no oversight, he's treating the patients for whom you have responsibility. Agency-level responsibility, and as we've established, personal responsibility. Dr. Sharoni, did you have a chance, Dr. Smith, to hear the first panel? Did you listen to the testimony from our first panel of witnesses? Yeah, he stated to a subcommittee that it appeared this doctor was operating with no oversight at all. Is that accurate?
Again, the only type of oversight that we had in place for an off-site provider at the time was going to be through the medical claims process. We didn't have any utilization management, utilization review. Part of our modernization program is to put those things in place so we can detect those types of things before they happen. And we're in the process of doing that.
Thank you, Dr. Smith. Dr. Hearn, forgive my interruption, but you had begun to explain how responsibility is shared between LaSalle and the federal government. You'd noted that IHSC makes determinations with respect to who the off-site providers are and approves the referrals. Is that correct?
That is correct.
Okay. Please tell me more about the balance of responsibilities between LaSalle and the federal government.
Once a provider on site determined a specialty appointment was made, it was presented through a MedPAR authorization to IHSC, and once the MedPAR was approved through IHSC, then the mechanism existed where the approval was transmitted to the unit, and the unit then scheduled the appointment with the approved provider.
Thank you, Dr. Hearn. So again, turning to you, Dr. Smith, describe the approval process whereby your agency approves the surgeries and other procedures requested through the referral from the private operator.
So all those referrals, surgical referrals, are referred to our regional clinical director, and they review those.
What does that review consist of?
That review consists of taking a look at what that patient is being reviewed, or being referred for. At the time, we didn't have the specific evidence-based guidelines in place, so they were using their best judgment on those things as a clinician. Since that time, we have...
So these are doctors who are making these determinations, yeah. So they're using their best judgment. What does that mean? What criteria are they accountable to? What guidance did you give them? What's the policy?
Well, the guidance is, if they were being referred off-site because the clinic didn't have the expertise to provide that, obviously the right thing to do is not to keep them at the clinic and try to provide care for them there. We needed to get them off-site, and so they would make sure that, yes, they're going off-site to a provider that has those types of qualifications. And Dr. Amin was that provider that was willing to see our female patient population.
And are these individuals, these physicians making these determinations as part of your agency, are they specialists in the relevant field or are they generalists? What are their specialties typically?
They have specialty care, internal medicine, family medicine, those types of things, which have a certain degree of OB specialty, I might say, knowledge, enough knowledge to know that when they're being referred to an OB physician, that that's the right place for them to go to be seen for their off-site care.
Do these physicians look at the nature of the complaint and assess whether or not the treatment that's being requested is clinically indicated?
To the best of their knowledge, with the information they have at the time, yes, but
do they refer to, I mean, so how did it happen that repeatedly, as you heard from our medical experts, the underlying condition was treated with a course of treatment that was not appropriate for the underlying condition?
I have no way of specifically knowing what they knew at that time when they referred them.
Have you asked them?
We have asked them.
What'd they say?
They said based upon the information they had through the referral process, that they thought it was the appropriate thing to refer them off-site to a higher level of specialty care.
Dr. Hearn, I believe in your testimony, you stated that when these allegations became public, that you undertook a review. Is that correct?
That is correct.
Why did you do that?
The allegations were extremely concerning to LaSalle and to myself, so we immediately began a review, an internal review at that time.
You began the review because they were concerning. They certainly were concerning. Were you advised by corporate leadership to undertake that review? What was the decision-making process to launch that review?
The discussion between myself and the CEO concerning the allegations.
And how long did that review take?
That review had started the day after my discussion with the CEO, and it has continued throughout until this very day.
That's a little bit different from what we heard from the company previously. We understood, and we can refer to the relevant part of the interview, that it was a 3-day review. What does that 3-day review refer to?
The 3-day review was to go on-site and review documents at the facility, discussions with the medical leadership and with the unit leadership.
And what did you find?
I reviewed medical charts, and I reviewed discussion with the leadership, and at that point,
Okay, forgive me. You reviewed medical charts and discussion with leadership. Here's what I'm trying to understand. It took a team of professional investigators from both political parties here in the Senate 18 months and consultation with a significant number of outside medical experts to go through tens of thousands of pages of medical records in order for us to arrive at these conclusions. So how could a 3-day review have possibly been sufficient for LaSalle to draw any firm conclusions about what happened here?
my review involved the process of referral. The process of referral at the unit, and the appropriateness of the referral, and the approval process that the referrals were approved.
Okay, let's talk about that referral process. As we've heard from our medical experts, there was a consistent pattern, a course of treatment that this provider consistently undertook. And generally speaking, it began with imaging or examination procedures that were not clinically indicated by the underlying complaint. Then a statement by the physician that the first intervention would be a Depo-Provera shot, a contraceptive injection. And then on the basis of, for example, imaging, a transvaginal ultrasound that may have been performed, a determination that there were cysts present, and a statement by the physician that if it didn't resolve in a number of weeks, they might proceed to some surgical intervention. And in many cases, the doctor did cut these patients, laparoscopically, dilation curettage, a range of other procedures. You said that when you make that referral, are you assessing, are your medical professionals assessing whether the course of treatment that is proposed by the off-site provider is clinically appropriate given the underlying complaint?
The medical provider is reliant on the expertise of the specialist.
I need you to be a little more specific. The medical provider meaning your employee on site.
The on-site medical provider is dependent upon the expertise of the outside medical provider.
So do they accept the outside provider's recommendation without any review, without any question?
There is a review of the medical documents that are presented, but they are very limited oftentimes from the outside provider.
And why do LaSalle personnel undertake that review? Why do the clinicians on site at your facilities review the underlying documentation submitted by the specialist to determine whether or not the procedure is appropriate? Why do you do that?
The on-site providers do not have the clinical expertise or the knowledge of the specialist referral, but you are looking to see and seek approval for the treatment that has been recommended by the clinician, the outside clinician.
Say that last part again. You're looking to see what?
You're looking to see the you're looking to see the treatment that was recommended by the outside provider, and then that goes into an approval process with IHSC because any follow-up appointments are approved by IHSC.
Right. So I'm not getting clarity on whether or not your personnel on site, the clinicians on site at LaSalle facilities, are making a determination about the propriety of the proposed course of treatment. Are they just rubber stamping it, or are they looking at the record, looking at the complaint that's been diagnosed, and making an assessment as to whether it's the appropriate course of treatment?
They are not making an assessment.
So what are they doing?
Appropriateness of
They're
treatment.
just referring it to IHSC.
Yes.
So they don't exercise any discretion and they approve or refer 100%.
They're referring all recommendations to IHSC.
So your testimony is that it is entirely the responsibility of IHSC to assess the propriety of the proposed intervention.
Any referral, follow-up appointment, or procedure is approved by IHSC.
You said that your review is ongoing to this day. So what steps have you taken subsequent to those initial 3 days, and why have you taken them?
Well, with the subpoena that was issued, I personally reviewed page after page of medical records that were on paper until September 2017. Then we had electronic health records, and we pulled electronic health records to maintain and be able to comply with the request from the subpoenas.
So just for clarity, Dr. Hearn, what you mean when you say the review has continued to this day is that you have complied with this subcommittee's and perhaps other agencies' processes for securing information, but you've not undertaken any additional review yourself of the underlying records, the propriety of the treatment provided by Dr. Amin. Is that correct?
During my document production, there was some review that goes along with document production as well.
I see. So in the course of providing us and other potential agencies with those documents, you looked at them, is what you're saying?
Yes.
Okay. Thank you,
Not
Dr. Hearn.
everyone, but some.
I hear you. Inspector General Kufari, I know that the Office of the Inspector General is currently engaged in its own review of this matter. When can we expect you to complete that?
Senator, in an open setting, I would be remiss because we're touching on other agencies within the executive branch that have equities in the matter you're asking about. And I don't have a timeline to give you in an open setting.
What steps can the Office of the Inspector General take to ensure that these grotesque failures and abuses never happen again?
To continue our vigorous and objective oversight of the Department of Homeland Security and ICE detention, to include CBP detention as well.
Thank you, Inspector General Kufari.
Yes, sir.
This will conclude the questioning for today's hearing. The record will remain open for 15 days for submissions. I gotta just say, this is such an appalling case. I'm repeating myself, but as I said earlier, I can't think of much of anything worse than this. Unnecessary surgeries performed on prisoners. Give me a break. It is an abject failure, Dr. Smith. It's a disgrace to the federal government. And what we've heard today is that there was no real vetting. Your assessment appears to be that if you'd undertaken vetting, you wouldn't have found anything. Well, that suggests you're not thinking creatively enough about how to vet these providers, because there were red flags that should have at least provided the basis for more careful monitoring of this physician. And that basically there were no processes in place, no due diligence, no review, no way to monitor for red flags. The data was warning you, but you weren't looking at it. And a lot of people got hurt. We'll have follow-up questions. Drs. Smith and Hearn and Inspector General Kufari look forward to the conclusion of your ongoing work related to this matter.
Yes, sir.
I thank you all for your presence today. I, without objection, will introduce this full report into the record and adjourn the hearing.